measure this forebrain, Eric? David? David?
Don't know.
Okay. Well, let's take a look. Here we have midbrain. Pons. Sullen. Spinal cord. Aqueduct. Fourth ventricle. Ring 5. Cerebellum. Cerebrum. And here we have the vertebral arteries coming together on the basilar. And here we have the carotid artery coming up. And you can write the middle cerebral, which is going to come straight out at us. And given by the forward, comes now lateral view, so we're going to bury it. Anterior cerebral, around the bosom. And we better have a posterior communicating come in here. Direct the basilar. And the posterior cerebral coming off. So we have middle cerebral, anterior cerebral artery, and posterior cerebral artery. There's 3 major cerebral arteries, those you know. Off of the basilar, we have continuation here, the superior cerebellar. And off of the vertebral, the posterior cerebellar. And off of the basilar, an anterior inferior cerebellar. 3 there. Those are all suprasegmental arteries. And you'll recall that I said the other suprasegmental structure, the cliculi, receives vascular supply from the 2 cerebellar cerebral suprasegmental arteries, rather than have its own blood supply. Now, of course, the spinal cord has no suprasegmental structure, so we're not going to have that 3rd major branch. Now, when I refer to that as a 3rd major branch, I'm referring back to the classical brainstem section. My posterior hindbrain. With the, well, let's put in some cerebellum. The flocculus, the rest of the cerebellum, and the nodulus in here, the rest of the cerebellum. Structure there. As to vascularize. Vertebral arteries. And now with 3, a basic pattern of 3 blood vessels, arteries, paramedian, lateral, or short circumferential, and on the right side I have constructed paramedian, short circumferential, long circumferential, or suprasegmental. And so those are the 3 major branches that we're going to see in a horizontal section through brainstem, and we would expect to see the same thing in the forebrain. Except the answer is going to be 4 instead of 3. like I said yesterday, this basic pattern holds true. Well, at this level, this is pipehead. And this is the lateral medullary arteries, plural. They give rise to the lateral medullary artery syndrome of Wallenberg. Whose major characteristic, of course, is the cruciate hemipalalgesia, catching the primary sensory neurons of the descending tract of the trigeminal and the ascending crossed thymic tract. So one has a ipsilateral face, contralateral body, arm, and leg, loss of pain temperature. That's the local signature, if you will. Local in terms of a couple inches of brain stem for this lateral or short circumferential series of vessels involved, half a dozen or so, every few millimeters, through the posterior hindbrain up to the middle hindbrain, and even up to the anterior hindbrain. So one can get a real local signature within that 2 inches, depending on which of the lateral cranial nerves is involved. 5, 7, 9, 10, and that lateral. This paramedian set of vessel, of course, contributes to the alternating hemiplegias. At this level 12, ipsilateral, contralateral hemiplegia. A little higher, 6, a little higher, still 3. So we have that basic pattern of medial, lateral, alternating hemiplegias, cruciate hemipalalgesias throughout the whole, almost the whole brainstem, midbrain, pons, medulla. And superimposed on that, the third major artery, the suprasegmental one. At this level, posterior inferior cerebellar, next level up, anterior inferior cerebellar, next level up, superior cerebellar. But these three major arteries that you see in all the diagrams are just the third of the three patterns that you're going to see at horizontal levels. Now, I emphasized yesterday how these arteries condense somewhat irregularly and unpredictably from person to person from a diffuse vascular network. And the corollary of that is that these major arteries can have one or more collateral anastomotic channels, major arterial anastomotic channels. And the same is true between anterior and posterior cerebral arteries, and between middle cerebral, you come up on the surface, you come down. Hard to draw in 3 dimensions of middle cerebral coming out towards us, curving over the top. We can have these anastomotic channels, which you can see in a 20-week gestation fetus normally. They represent the next to last stage of this diffuse nerve vascular net that is condensing into major arteries. And you can see half a dozen or more of these very straight arteries, middle and anterior, coming up over the superior medial margin of the hemisphere. The next step, along about 24 weeks, 28 weeks, you're going to see these breaking. And it is as though, I don't really know why it is as though the head of pressure middle and the interstitial meet. And there's essentially no flow at that junctional point. And so it atrophies. So you end up with end arteries. There are penetrating branches, of course, that come down into the brain, so there's no real difference in supply to the brain. If you've got a normal, equal head of pressure, the branches are going to supply the developing brain, whether there's an anastomotic channel or not. The advantage to having one or more anastomotic channels persist, of course, is usually in the adult, at any age, when one artery is occluded. If you don't have any anastomotic channel, take infarct, that's whole distribution. If you've got a channel, you can get almost, or even complete, reflux through that channel to supply all the other branches, and you have no infarct at all. Or, depending on how the blood flow actually accommodates itself, a smaller infarct than you expect. So the presence of these anastomotic channels is normal for 20 weeks and persists in variable numbers through adult life, and if they persist, create the potentiality of escaping infarction following occlusion of any particular major artery. And it's sort of like the circle of Willis at the base of the brain, where you have, in theory, a complete circle. You could survive on one of the four major arteries, 2 for T plus 2 for carotid, if the circle were complete, and all the vessels were nice and normally bounded. I've seen one patient in that situation who was perfectly normal, blind in one eye, but otherwise pretty good. But most people don't get to that stage. We have anastomotic channels most of the time, in circle of Willis, and some of the time cerebellar or cerebral on the surface. Many questions about that general problem I'm about to go into now, the forebrain, and show how this basic pattern persists, but is supplemented by one more. Any problems? Well, let's take a look at the forebrain. Let's look at it first in a coronal view. Epithalamus, thalamus, hypothalamus, thalamus, hypothalamus, caudate, putamen, lobus pallidus, tail of caudate, claustrum, insular cortex, temporal lobe, frontal lobe. Oh, I better put a corpus callosum in here. Cingulate gyrus, and on around. And of course, coming up here, we have the carotid artery bending over into the middle cerebral artery to run out as several branches here over the insula and continuing out over the surface of the brain. Giving rise to branches that come in, so on. Well, the anterior cerebral artery, having come from the carotid around genu forward, doing the same thing, giving rise to branches that come up over the surface, and the anastomotic channel between the two. The normal division being Suprafrontal gyrus supplied by anterior cerebral, and middle and inferior by middle cerebral. So this region is known as the watershed, or border zone. And it is a place where, anastomotic channel or not, a drop in the head of pressure results in decreased perfusion in this region from both sides, anterior and middle. So patients who have a carotid occlusion, as when they're strangled, or patients who go into shock, this will be the site of predilection for dysfunction and necrosis. Coming off the carotid and going backwards, away from us, of course, is the posterior communicating artery, right angles to the board. And it's going to give rise, that's the primitive caudal branch of the primitive internal carotid, primitive diencephalic artery. It's going to give rise to branches that come up as medial or paramedian. Get the analogy straight. Paramedial branches to hypothalamus, medial thalamus. The middle cerebral artery and the anterior, slightly forward, give rise to branches that are striatal branches. They are lateral. So we have exactly the same analogy we have in the brainstem. Paramedian, lateral, and long, circumferential, suprasegmental, cortical, cerebral arteries. And that would be fine if we didn't have one other structure coming in here. And that is the development of the globus pallidus and the lateral ventral thalamus as an expansion laterally from the medial thalamus hypothalamus. We have too large a diencephalic pair, expansion of lateral thalamus and migration of globus pallidus, to continue to be supplied by these paramedian branches. And so a new vessel appears to supply the globus pallidus, ventrolateral thalamus, and that's the anterior carotid. Now, continuing back in the third dimension, away from us, the equivalent branches of the posterior cerebral, posterior choroidal, and posterior thalamic branches come in to supply the back end of the thalamus. So that the supply to this region of the brain becomes complicated, depending on how low down, how high up you look. a striatal point of view, since the caudate, body, tail are supplied by striatal branches, the internal capsule is going to be supplied by these striatal branches. That's relatively high, internal capsule. Lower down, because the globus pallidus ventrolateral thalamus are essentially next to each other and the internal capsule between them, the involvement of the capsule is going to be by anterior choroidal. And still lower down, as we get to the cerebral peduncle, it's going to be supplied by the circumferential arteries of the comparable to these lateral branches of posterior hindbrain. They'll be coming off of either posterior cerebral or supracerebellar arteries. And rostrally, we have the same kind of striatal branches coming off of anterior cerebral, one of which, given the name of the recurrent artery partner, there's several of them that come in from anterior cerebral into the striatum, anteriorly, ventrally, and medially, as the remains of the old olfactory artery. The anterior cerebral, you recall, was the continuation of the rostral branch of internal carotid. It was a really primitive olfactory artery. So that basal olfactory area, which is back in the human, back to the anterior periphery space. The anterior periphery space is due to these striatal arteries. That whole region gets to be supplied by the striatal branches in the middle, mostly, but also anteriorly, the anterior cerebral artery. So any questions on that view? Because next I'd like to go to a horizontal view to show how these are coming up through a horizontal section. Horizontal section. Well, let's start with the thalamus. Wall of third ventricle, posteriorly, laterally. On the other side, third ventricle between. And we want some cornices, and septum, and corpus callosum. And so we're going to put a head of caudate in here. So that we have the posterior limb, anterior limb, globus pallidus, putamen, and put a little head of caudate back here. Divide our thalamus into medial, and lateral, and interlaminar groups. Put a little claustrum outside here, some insular cortex, temporal operculum, frontal operculum, and so on. Better put a cingulate gyrus up here so you can have some orientation. And we better put a corpus callosum back in here, orientation, and maybe the back end of cingulate gyrus. Okay. Observe for a moment. And so here we have the transparent brain now with the internal carotid coming up below, hidden. Continuing on as the middle cerebral artery. Now here, lateral fissure. And giving rise to a branch. The anterior cerebral artery, which is going to come up and around the genu. posterior communicating artery. Back, or back on. And I guess down below, through this transparent brain, we're going to put in the basilar artery coming up, branching into the superior cerebellar. Next branch, posterior cerebral. And that's going to curve around, and we'll have a posterior communicating jump joint there. Should have an opening here. Posterior cerebral. All we need is a posterior on this side. Junction right there. So here's half of the circle of Willis with the internal carotid. Middle cerebral. I understand, David, you've been allowing this to run through the clock chimes, but serve as a marker for some of those who watched it. Anyway, middle cerebral, anterior cerebral, posterior communicator, down to posterior cerebral and superior cerebellar, basilar. And this would be P1 between basilar and posterior communicating. Posterior communicating branches coming up towards us to supply medial thalamus, hypothalamus. These branches. Striatal branches coming up to supply striatum, head of caudate, putamen, tail of caudate, a series of branches that are fanned forward and backwards from this laterally running middle cerebral artery. It's nothing more nor less than having the middle cerebral come out laterally. Take a 20-week-old fetal brain, which is about the size of my thumb. No sulci, just beginning indentation of the lateral fissure. Middle cerebral coming straight out and over the base of the insula. And penetrating branches going up into the striatum, which has already begun to take some of them with them, back and around, and forward. And so we have a series of arteries that would like to come out perfectly vertically, perfectly laterally. We get distorted rostral, caudal, as part of the frontal migration, parieto-temporal migration of the developing brain. So these branches are generally in the adult going to be caught tangentially, obliquely. We'll cut the brain routinely coronally. And so there are going to be a few that will come straight up. Most are going to be going obliquely forward or obliquely backwards, so we're not going to get them in straight lines. Get little segments of them. the cerebral branches, cortical branches, of course, resupplying the outside, cortex, subcortical, white matter. But now we have in between here anterior cerebral penetrating branches coming in here to supply the most ventral medial portion by recurrent branches from anterior communicating, anterior cerebral, A1, branches coming back from the rostrally directed anterior cerebral. These are coming back to the old basal olfactory region and catching the most ventral medial part of the head of the caudate. A centimeter or so cross section. The anterior choroidal, which comes off the internal carotid just a millimeter or two superior to posterior communicator, now comes into supply the lobus pallidus, the ventral lateral complex, the thalamus, and the intervening posterior limb of the internal capsule. From below. So here we have the inferior part of the posterior limb supplied by anterior choroidal, and the superior part supplied by striatal branches. Because in 3 dimensions, the striatal branches are coming up here, lateral and superior, to the choroidal branches coming from below. If I had enough hands, I could have relatively short branches of anterior choroidal coming up here, really long branches, striatal branches coming up here. And so the internal capsule, which is coming down in this direction in the scheme, would be caught by striatal branches or choroidal branches. Or as we go down still further, follow the internal capsule down into the cerebral peduncle, they'll be caught by the paramedian or short circumferential branches of the posterior cerebral. I still see some winces. So I'll try and draw the midbrain upside down again. Aqueduct. Aqueductal gray. Folliculus. Peduncle. Interconjunctive fossa. Peduncle. Folliculus. Nigra. Basilar artery. Paramedian. Short circumferential, long circumferential, so posterior cerebral artery, lateral, paramedian, and these little branches off the peduncle. With the posterior communicator at this one. So the anterior limb fibers, which are going to be, say, frontal pontine, If I put those in purple. Pontine fibers coming down from frontal lobe into the anterior limb, down in here immediately.
the temporal parietal occipital pontine fibers coming in underneath from temporal lobe. Beneath the lentiform nucleus in the sublenticular limb, coming in laterally. So here's temporal frontal pontine fibers. The face, arm, leg of corticospinal tract fibers. Down his middle region. Of course, the ascending thalamocortical. Coming from VP, VPL, VPM, going up. You won't see those unless you feed them, of course. What we'll see will be the subthalamic, prethalamic, medial meniscus, spinothalamic tract. Before they get to the thalamus. So it's a three-dimensional little jigsaw puzzle to visualize in a series of horizontal sections, midbrain to inferior level of capsule, superior level of capsule, with these penetrating vessels coming up, with the striatal branches being the longest and most lateral, and catching the capsule highest up, which you can't see on the horizontal sections very well because they're coming up much more laterally and superior. The anterocoroidal, very inconspicuous artery, but supplying a very important part of the internal capsule. Right at the junction of cerebral peduncle and thalamus, right at the level of the optic tract, chiasm tract coming back here, and the lateral geniculate. Which is also being supplied by the anterior carotid artery. And so this vessel, which by name is going into the choroidal fissure to supply the choroid plexus, anteriorly in the temporal lobe, and more posteriorly, finding it back into the glomus, the trigone, there is posterior choroid. A horizontal accessory circle of Willis from anterior choroidal to posterior choroidal, essentially in the temporal lobe immediately, with clinically important branches coming up into internal capsule. The major gross landmark for the brain in your hand to find the anterior carotid artery is to look for the optic tract. Because the anterior carotid artery is right along. Posterior communicator is toward you, as inferior, running roughly parallel to it. It is, of course, an easily seen artery between the carotid and posterior cerebral, which just deep to that, just away from that, just superior. As you're looking at this brain upside down, you will see the anterior choroid running right along the optic tract. Back to lateral geniculate, giving rise to branches to the most inferior part of the internal capsule and most inferior part of the lateral thalamus. And it just so happened that yesterday at St. Peter's Hospital we saw a case which David has here, and we can probably take a look at it. You haven't photographed it yet, David? About time to unveil it and photograph it anyway. Got some gloves? You see here the cystic infarct, the depressed wall of the ventricle, preserved ventromedial anterior striatal arteries, involved lateral striatal, middle cerebral. And that enlarges laterally, back at the level of the anterior commissure, and Monroe's foramen, choroid plexus going through from lateral to third ventricle. The infarct enlarged out into the putamen, sparing globus pallidus, probably involving caudate at a slightly different level, likely to this region. On the other side, we begin to see a little tiny infarct here in the globus pallidus. That enlarges here to involve globus pallidus, internal capsule, thalamus, and a little piece of hippocampus. There's and the lateral and the optic tract here. There's exactly the territory you would expect from the anterior choroidal coming through the choroidal fissure just by the choroid plexus and temporal horn. A little adjacent hippocampus, the main target globus pallidus, ventrolateral thalamus, and the internal capsule and cerebral peduncle. A fairly large lesion, almost 2 centimeters square. But the striatal branches, upper internal capsule, caudate, most of the thalamus are intact. Spinal cord has, of course, an anterior spinal artery, and from which come paramedian and short circumferential, and a small pair of posterior spinal arteries. So one has an anastomotic channel potentially around the whole spinal cord. But these two, paramedian and lateral, short circumferential, are exactly analogous to the brainstem pattern. And if there were suprasegmental structure over spinal cord, you'd have a third one. don't. And so it's reduced to essentially these two channels. Now, the anterior-spinal artery, of course, is typically supplied by two major remnants of the segmental arteries that we talked about embryologically yesterday. You recall how the segmental arteries for the whole hindbrain, anterior, middle, posterior, atrophy down, so we have the vertebral basilar left. The same thing is happening down in the spinal cord as these segmental arteries disappear. We have the vertebral coming up, and down in the spinal cord area we have usually about, a C5, somewhere there, and way down lumbar, L2 say, two major segmental arteries with the collateral channel, anterospinal, persisting. The watershed between those two, patient has decreased perfusion, shock, is somewhere around T6. Exactly comparable to the watershed up here between the anterior and middle circular arteries. And there is, as you know, from the vertebral, a pair of anterospinal arteries above, so we have a rather long, from posterior hindbrain on down, anterior spinal artery system that is supplied the rostral end from vertebrals and intermittently by cervical and lumbar persisting segmental arteries. The result is that there are two basic syndromes of spinal cord. One paramedian, mostly the gray matter, and one lateral, mostly to the cranial tract. And some of the ascending sensory pathways. But the collateral circulation between these two is somewhat variable. So the extent of the gray matter or white matter damage varies from one person to another. In patients who had a bypass or aortic replacement, the bypass has not been sufficient. So if there's decreased perfusion, the gray matter tends to suffer more than the white matter. So we have a large infarction here in the gray matter, including the association plate. So it's possible, if the anterior horn cells escape, it's possible for the deep posterior horn gray matter, mostly related to the polysynaptic reflexive response to pain, to be destroyed, resulting in an extensor hypertonicity. So in special situations one can get a rather selective extensor spasticity. due largely to loss of flexor, reflex sector. The lateral syndrome, on the other hand, is probably one of the monoplegia, upper motor neuron. So in theory, if we had enough involvement of gray matter, one could see a segmental local signature of weakness of thoracic abdominal muscle. But that isn't good enough. You don't get to see that. You can see the monoplegia out here in the leg, but no really good local signature of just where the lesion was. Not really till you get up in the first hindment you get that local signature, 12, 4, 9, and 10, out laterally. So, there we come to virtually the end of the course, except for the exam question. The patient that I gave you. And how many did you get up to, Jim?
Well, I only got like 6 or 7.
6 or 7. Larry, how many did you get?
Yeah, for this weekend.
Save it for the weekend. David, how many did you get?
I think I stopped thinking about it after about 3.
Oh, I can see you're having trouble then. More trouble than I thought you would. Well, let's take a look at it for a moment, just to get you back on course. We have a patient who fell, who was weak in the right leg, who had a sensory loss, weak right leg with decreased deep reflexes. And a tumor. Because of the major features I gave you. So one can have two groups of patients. As whether the fall caused the rest of it or didn't. He fell and the rest resulted, or something happened to him and he fell. The fall is essentially irrelevant. How many patients can we have, how many groups of patients can we have with weakness of the right leg, with decreased reflexes? Very good. Well, I come to you with a weak right leg. Now remember, this is a neuroanatomy course, so we're thinking as anatomists, not particularly as clinicians. And you see this weak right leg, and what do you think? I mean, in the whole universe of weak right legs, there are two possibilities. Actually, 3. Let's skip over 2. Jim? Right. Upper motor neuron, lower motor neuron. So we got, it could be 2 groups. Let's see. It's relevant or irrelevant. So as the ball goes, it's upper motor neuron or lower motor neuron. We know it's relevant because we see it. And how many kinds of sensory loss would there be in terms of place? 2. That is in the same leg, right or left. Okay. There are probably a couple more we can think of in terms of kinds of sensation. So we might have another couple that would be say all sensations or selective sensory loss. That's pain temperature versus the light touch. And how many patients are going to have with a tumor? How many groups of patients with a tumor?
2.
2. Where are they?
Relevant, irrelevant.
Right. They're either relevant or irrelevant. On short notice, I'm not sure how many other red herrings I put in here. But anyway, you've got something in the order of 2, 4, 8, 16, 32 patients in your waiting room who've come into you with this story. Because you're going to have to dissect apart and find a place, roughly 32 places, find a story, roughly 32 stories, that would fit. Half the patients are going to fall and have this result. That means 16 results. Half are going to have the 16 results, and the fall was irrelevant. Red herring, thrown away. Something else caused it. Half of them are going to have a tumor that the neurosurgeon and the pathologist saw at autopsy that caused it. That was important, and why the neurosurgeon went into shock and forgot his physical findings. Because as you recall, he was put the patient back the weekend, so in fact we'll study on Monday. Let's see if you're nothing better by Monday. And so he obviously forgot what he'd written and seen with the death of his friend and the vision of the tumor. Or otherwise, if it was a perfectly straightforward case, with that sudden onset, he wouldn't have had a tumor. The surgeon would have said, it's a bit like this. He would have remembered that the weak right leg with decreased reflexes was either upper or lower. That the sensory loss was either same or other side. Like those are straightforward observations that he just blanked out on. Double shock, the loss of his friend, and seeing a tumor. Now for neurosurgeons, and no neurosurgeon here this morning, but neurosurgeon for a tumor, missed. I mean, that's tragic. Most of us know that tumors have acute non-tumor. Doesn't mean everything diagnosed with tumor. It's just that neurosurgeons don't know. But so that's sort of the setting of the case and the setting of the weekend exercise for you. So Monday, we'll try and finish up the course centered around this case and the 32 sites that would accommodate your waiting room full of 72 patients.
So you still don't get to know where the tumor was.
Yeah. And then I'll show you the slides of the particular case, the one of the 32 possibilities. Not necessarily the most logical,